the general public who's not in the industry like we are, I think that they think that healthcare is just expensive and this is just the way it has to be.
Yeah.
And it doesn't.
Yeah.
And I think if more people knew that, they would rise up and fight the system.
Pitchforks.
Fight for change. Yeah.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare.
At what age is a kid old enough to be like your built-in babysitter for a younger kid? When were you comfortable with your oldest watching middle
just for
kid?
little, like if I'm going to run to the grocery or something, she was probably like 9 or 10.
Yeah, that's what I was thinking, about 10 years
Depends
old.
on the kids, right? Are they going to kill each other while you're gone? Do they actually like each other so it'll be okay?
Yeah, jury's out on that one.
Right.
But I think with the little guy's 4, daughter 7, I think, so if Brooklyn was 10, Bash would be 7. She's pretty mature, so I feel like she would keep him in line. And just as long as he doesn't put himself in physical danger, that's always my fear with him, is physical. Like he's
He's a
clumsy
boy.
and he's a boy.
Yep.
Yeah. What did he do the other day?
But then you enter this whole other can of worms. Like you probably don't have a landline, right?
No.
Right. So now you're leaving and your 10-year-old daughter's at home. Do you have to get her a phone now so that she can
Do
call
I have to get her a phone
911?
now? Mom already got her a Gab phone, which is a kid phone, which you can only text and call on. And she has like 3 numbers saved, which is like our 2 numbers and Mimi.
Yeah.
So we wouldn't have to get her a phone because I'm already
Good.
paying
She
for
can
a
call
phone.
911 from her
She
Gab
can call,
phone.
or she can call us, right?
Right.
Which would
Okay.
be, and then we have
Well, then you're good.
Alexa's literally spying
yeah.
on us in every room of the house, so
Alexa
we can
can
get a
call
hold.
you.
Yeah, Alexa can call us. But yeah, that's my big fear is like, when do kids start learning to cook and turning on the stove or microwave? Because then I'm like, oh God, that's a new set of dangers.
You have to worry about fires.
Yeah.
You know, then you have to have that whole lecture about we don't put silverware in the microwave.
Metal doesn't go in the microwave.
Yes.
Yeah, that's
Legit. One of my 13-year-olds FaceTimed yesterday and he was like, how do we make a quesadilla? And we had to march him through the whole thing. First, you get out the skillet, then you put in the butter, then you do all this.
Was he able to navigate it?
I think so. And I was
Okay.
like, also, don't burn yourself.
Yeah. Yeah, the pan is
Also,
hot.
turn the stove off when you're done, please.
Yeah. That's the big one, is remembering to turn the stove
Yeah.
off. Yeah.
There's just all these things.
Yeah,
that
now I'm like, maybe when my daughter's 18, I'll let her babysit. Yeah, maybe that's the right age. Right, well, Jenni, I guess we're going to go. Nathaniel, we're probably good. We'll capture a good story about parenting maybe at the beginning of this episode.
Yeah.
About
I'm a parenting expert.
Yeah, I'm not a parenting expert, that's for sure. I'm trying to figure it out.
If keeping them alive is your only goal, then
Yeah, keeping them alive
I
and
think I've got
out
that.
of jail.
out of jail is good.
Yeah,
So far, no jail.
Those are my 2 like
Although
big
we could
criteria.
tell you stories.
You
but-
got okay. Well, we'll save them for off the podcast just in case. But Jenni Nolan, I'm here sitting down with you, and we're going to talk patient advocacy today. Is that
Yeah.
correct?
Yeah.
Awesome. What is the name of your company? I'm sorry, I didn't
It
even.
is a mouthful. Clear Healthcare Advocacy.
Clear Healthcare Advocacy. Oh, I saw you typing in your email.
It takes like 10 minutes
Is
to
it full
type it in.
at Clear Healthcare Advocacy in your email
Yes.
handle? Okay. Where does I think I understand the premise behind the name, but how did you develop the name?
Wanting to pull in like the whole clarity and trying to make things clear for patients, obviously. I wanted clarity patient advocates and it was already taken.
That was already taken.
So,
Okay.
Yeah. Turns out it's like a fellow advocate that I really like. So, yeah. And it's a mouthful and I wish I could have done it differently, but too late now.
Well, we're notorious for acronyms, so we clear
CHA.
CHA. That's perfect.
CHA.
She owns
Yeah.
CHA. We'll say that. Okay.
Yep.
Well, so Jenni, I think obviously we've already let the cat out of the bag. We're going to talk about patient advocacy. Before we go into your bio and your backstory of who you are, could you, in your own words, define for me what we mean when we say patient advocacy? What does that mean to you?
Yeah. So just working on behalf of the patient. I'm an independent patient advocate.
Okay.
So I'm working on behalf of the patient. So you'll hear patient advocate thrown around in the hospital. They have patient advocates who are working for the hospital. Insurance companies have patient advocates who are getting paid by the insurance company. I'm getting paid by the patient. I'm working for the patient.
You're paid by the individual. And we talk a lot about healthcare incentives on this podcast, but I see obviously social media a lot of times like incentives matter because incentives work, and who pays whom really does sometimes impact the recommendations that come. So you're very clear about independent and you work for the patient, which is awesome.
Absolutely.
Okay. Well, so let's go back now. How the heck did you get into this world of patient advocacy? I think you have a pretty interesting backstory. So I'd like to hear about growing up, and take me as far back as you'd like to go.
Yeah. We'll start with college, which seems like it was 100 years ago. I have a degree in health information administration from Indiana University. So it was a combination of like business and clinical. And then my goal was to start off in physician office management and work my way up the ladder at a hospital, probably.
How did you discover an interest in that, or what made you pursue that as a degree?
So my degree, well, that was just kind of like, I started off in accounting and then decided I didn't want to do that. And it was like, what can I do that a lot of my credits would transfer, right? What was the easiest thing that could get me out of here in 4 years? I had a little bit of interest in healthcare, but zero interest in this is going to sound horrible, touching people. I don't want to draw your blood.
Yeah.
I don't want to.
So nursing wasn't going to be a thing. Yes.
So that was interesting to me.
Well, now what the accounting pursuit originally, though, was that your own personal interest? Did you have family members that were accountants?
No,
that
was like I took a accounting class in high school and I thought it was cool.
Yeah. But you obviously pivoted at some point. So did you realize it wasn't as cool as you thought a couple years in, or what?
I sat down at one of my first accounting classes, and the professor was like, I'm sure that you all subscribe to the Wall Street Journal and blah, blah, blah. And I was like, no, and I never want to. Maybe I shouldn't be in this class. And I just kind of like, meh.
That's hilarious.
Yeah.
Well, are you glad you made that pivot? I mean, okay.
Yeah. It's definitely been interesting these last 5 or so years. Yeah.
But you said then you got into the sort of the hospital kind of administration side, or wanted to maybe go that route, end up maybe running a hospital was a part of your trajectory?
So the whole, I guess the focus of a degree in health information management is it used to be called medical records administration. So we were literally the people in the basement of the hospital doing the coding, keeping the medical records, release of information, all that stuff. I knew that that's not what I wanted to do with it. So I thought I'd take it a slightly different route and go into physician office management. Okay,
cool. And so you had a career for a while doing that, correct? Mm-hmm. And then you hit pause, and I did the stay-at-home mom thing for a number of years as well.
Yeah, a little bit. So I did physician office management. I managed an OB practice for several years. And that's where I really got involved in the whole billing process, the insurance process. Learned the lingo, how things worked, and what a mess it is, essentially. It started with me trying to chase down money on behalf of my doctors. Every 30 days after we submitted a claim, I'd be like, where's our money? Call Anthem, where's our money? What's the holdup with this? And then just realizing how many errors there were, how many opportunities for error. Were we getting paid correctly? Were we billing the patients correctly? And then as I got more and more familiar with that process, I started realizing that a third for sure of the bills that came in our own home were incorrect. I've got myself, my husband, and 4 kids. We're not high consumers of healthcare, but a third of the bills that come in the house aren't right.
Well, you don't have to be a high consumer of healthcare to have errors in your bill. I mean, it's so ubiquitous. I've heard even quoted like 99% of bills have some sort of error. And maybe that's a little bit of an overstatement, but it just suggests how pervasive that problem actually is.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has 2 distinct parts. Number 1, to make self-insurance simple and more accessible for small to mid-sized employers. And number 2, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
When did you feel like you developed a passion for it, though? Because it's one thing to pursue revenue that's owed to you from an insurance carrier and get that correct. It's another thing to be passionate about advocating for individuals that are the recipients of these bills.
Yes.
So where did that come from?
So I think that happened just slowly along or over the years. You know, as I noticed that the bills were coming into my home incorrectly, I was like, what about all the other people who are getting these incorrect bills and they don't even know it?
Yeah.
So they're either writing a check for a balance that they potentially don't owe just because they hate to owe people money, or maybe they don't have the funds to pay for it and they're getting sent to collections for amounts that they might not even owe.
Yeah.
And what about all these people and what can I do to help them? That's kind of how it started.
Cool. And it started unintentionally almost, right? I think you're telling me, and I'd love to hear the story, the origin story, but it's not like you sat down one day and said, I'm going to build this business. It was almost like it came to you. So talk about that.
So every time I would get one of these incorrect bills at home, I would, gripe about it on Facebook, essentially, like get on there and bash my local hospital and how I was having to do their job for them. And people would start to comment like, you should start a business. You should help people with this, with their medical bills, because it's not just happening to me, it's happening to everybody. And so they were like, you should start a business. And I was like, I don't think somebody's going to pay me to help them do this. And I just started doing research and found patient advocacy. It's like a real thing. There's a board certification. So I sat for that in 2019, opened my doors officially in 2020, February 2020.
What is the title or the accreditation that you get for that?
So I'm a BCPA.
BCPA.
It's Board Certified Patient Advocate.
Okay.
It's the Patient Advocate Certification Board who certifies.
And you said you've also sat for the LSAT, which is the law degree, or I forgot what it's called, the test to go into law school. You said you thought the patient advocacy one was harder than
I did
LSAT?
Personally. I don't know if I was just having a bad day, but when it was one of those things where you have to go to a testing center. And you sit down and at this computer, take this test, and I walked out of there and I was
it on a Scantron with a number 2 pencil? It should have been.
It was, the LSAT was when I took that. The BCPA was 2019, so no.
The only tests I care about are the ones that you have to have 2 number 2 pencils. You sit down with a Scantron, and then you turn it in, and you get they scan it, and you walk away knowing your score. That's the only test.
Those are awesome, and my maiden name is Hirschberger, so my full last name wouldn't fit on the Scantron. It ran out of bubbles. So
you ran out of bubbles? So what did it end up being?
It was like Hirschba.
That's hilarious. So you got this. So were you resistant or almost reluctant to start a business? Because it sounded like people were pushing you, and you were maybe even skeptical of your own ability to monetize it.
Right.
But if that wasn't an issue, were you still passionate about the subject? And if it was possible, did you want to pursue that as a business?
Yeah.
Or so you stood it up, right? That you became a business. Yeah. What were you doing early on? Was this like here and there somebody would reach out, or how were you finding patients?
I opened my doors February 2020.
Perfect timing.
Yeah.
Yep.
So fortunately, it was a slow start. And I say fortunately because, March 15th, then the world shut down. So suddenly I had 4 kids homeschooling. And so it was really good that I didn't have a lot of my own work to do, because I had I think my twins were in 3rd grade, it was a crap show at our house. So it was a good time to not be busy. Yeah.
And did you have all 4 kids under the roof at that time?
Yeah.
And you were teaching them all as well?
If you want to call it teaching.
Yeah. I mean, can I ask what that was like real quick? Because my kids were so young. What was it like to actually have them in school at that moment in time?
It was horrible.
Okay.
I'm not a helicopter mom, so I barely read the emails that come into the house. So me sitting there, I'm not homeschooler. It was horrible. I have pictures of it. I tried to set up a classroom. I remember one day one of the twins wore a poop emoji Halloween costume while he was learning. I'm like, this is the way we're doing it here at the Nolan house.
Yeah, might as well have some fun with it, because it's less than ideal. I mean, my daughter was maybe 3 or 4 at the time. So she was even pre-K.
Yep.
My son wasn't born yet. So like, I don't know what we would have done, but even just being kind of stuck at home during that time with the one toddler, my wife wasn't working at the time.
Yeah.
So it's not like we necessarily had a schedule we had to keep and teach, but we found ourselves doing a lot of like outdoor exercise and stuff,
Yep.
just try to maintain our sanity and
Yes.
not drink too much, you
Yep.
know, because we get locked in the house. But
Yep.
I could imagine trying to, have 4 kids and then start a business
It was
simultaneously.
crazy times.
So then you would just get folks call you here and there, or what would happen?
Yep, that's just started to trickle in, like even over that summer, I would say. And it's just gradually picked up. I'm a part of several different patient advocacy groups, so we refer to each other. I have people come in off of Google. I'm on Facebook, Insta, LinkedIn, things like that. So.
Yeah. And so like you just basically, let's talk through what would happen if somebody engages with you, right? So you're an independent patient advocate.
Yep.
So you're predominantly working with individuals and families, not necessarily employers. Is that correct?
Correct.
Or do you do some employer-based stuff as well?
I have done a teeny bit of employer-based work, just negotiating a balance or two. Yeah.
So mostly individuals, right? So let's say I call you and say, hey, Jenni, I need some help. I found you on Google. What does the start of that interaction look like in your
Yep.
investigations and things like that?
So I just kind of get a little bit of background on about what's going on. And it's funny to hear a patient describe what's going on, because sometimes you're like, those words that are coming out of your mouth don't even make sense. So I try to get an idea of what's going on, but then always my first thing is going to be send me your bill and send me a copy of the EOB.
Okay.
So I can take a look.
Okay, so for somebody that's unfamiliar with this space, why those 2 documents are important? Why do you need the bill and the explanation of the benefits or the EOB?
Right. So the bill, obviously, you need to make sure it's correct before you pay it. And people usually just reach out when they think obviously it's incorrect or it's way overpriced. And then the explanation of benefits, so that I can see how insurance processed it. Should they actually owe this amount? Did the provider forget to, take the contractual adjustment? You name it. There's a million things. But backtrack. Yes, nobody knows what an EOB is, really.
Yeah.
A lot of times when I say, and I always say explanation of benefits first. They're like, what is that? Oh, that's the thing I get, and I throw it in the trash. And
Right.
I'm like, oh my gosh. Then
Yeah.
I just like, oh.
Yeah.
Yeah.
So when I'm probably guilty of that as well, because that's not the bill, don't worry about it. And it's only usually until after you go, wait a second, what are they
Yes.
charging us? Then you get all angry, and then
Yeah.
that's when you start the investigation process. But so those 2 documents give you what? The majority of what you probably need to start.
For
but
sure.
Is that the full extent, or then you requesting additional records on the behalf later?
So then I can take a look based on that. I might have more follow-up questions just depending on what's going on. But the EOB pretty much tells me, like, was something processed out of network? Did we have, like, something denied because it didn't have prior authorization? We could go back and get retro authorization. There's a million things that can come up, but that gives me a good idea. And then I can say to the potential client, hey, here's what I think is going on. Mm-hmm. Here's what you would need to do to get it fixed. You can do it yourself, or I can do it for you.
Yeah. And most of the people want you to do it for them, I presume, right?
Yes. Sometimes it doesn't make sense to hire someone, obviously, depending on the amount of the bill. So there's a little, math that you do there. But I never turn someone away without pointing them in the right direction, telling them what needs to be done.
Yeah. Well, I think that's what you were saying is you're in a position, and I was asking this question, a lot of the patient advocates I've come across were female. And so I was asking the question if that was a natural thing or was an inclination towards it. But you also said you have the position right now, fortunately, where you can do some pro bono work when it makes sense. Obviously, you have to make a living, right? So nobody suggests you should work for free. But you have the ability when it's appropriate to be able to offer or do some of the stuff pro bono, right?
Yep.
Which is what does that mean, for free? Is that what
For
is
free,
it? For free,
I guess.
Okay. But and the reason I bring that up is like, that gives you a position, right? Because I think by nature, just what I know about you to start is like, you want to help people.
Yeah.
You have a nurturing kind of part of your personality. There's a justice component that we were talking about, which I think is evident as well, because it's, at the end of the day, this is a moral dilemma.
For sure.
Because if you see these things happening and somebody's getting raked over the coals and shouldn't be, you want to help them. Like I would want to help them as well. And so I think it would be very difficult not to be passionate about this as a subject.
Yeah. I'm very passionate
So
about
walk to me through like kind of a usual use case. Maybe if you have some stories, some examples of ways that you can help. Because I really want folks that are listening to this and go, hey, I could probably hire. I've got this thing. Like understanding what that experience is like and what to expect out of it.
So the possibilities are limitless, right? Like there's so many opportunities for error before you even go into the doctor's office. Like if I call and say, do you take Cigna? And they say yes, but we didn't clarify that I'm on the marketplace, so I've got a Cigna EPO policy, and you are contracted PPO but not EPO, right? So before I walk in the door, there's already a problem that's going to happen. Maybe I walk in and give you my new insurance card, but you're just not feeling it that day and it doesn't get to where it needs to go, and so you bill my old insurance. Like you name it, there's so many possibilities for error. So it runs the gamut. No case really is the same that I see. But just for a few examples, I'll just go back to like the very first one that I ever had. A guy who was getting some very expensive injections for a problem he was having. And I believe the provider had gotten prior authorization, which as some of us know, doesn't necessarily mean they're going to pay.
Okay.
And by the time they were monthly injections, so it wasn't until he'd already received the second injection that he realized insurance was not covering them. So when he reached out to me, I want to say it was like $26,000 in bills that he had. And so we needed to do an appeal. And I reached out to the provider, and they had already done an appeal. And I put that in air quotes because I was like, well, let me see a copy of the appeal because I'm doing a secondary appeal then. I don't want to just duplicate what you've already done since it got denied. So what does that appeal look like? And they sent me a copy of it, and it literally said, this is an appeal. Like, please pay for these injections or something like that. And I was like, that's not an appeal.
That's not an appeal.
That's not an appeal.
Just because you make the statement, this is an appeal, doesn't mean it's an official appeal.
Please, So I had to like go in and do research about the injections, what makes it medically necessary. I had to get medical records and put together this well-written letter with like actual evidence of medical necessity, send it in. We got it approved. They were covered as they should have been. I think he ended up owing like, I don't know, it might have been $1,000 or something. That his out of pocket that he should have owed. Yeah.
Well, that's a big win to start.
It was a good win to start. It was a good start. I was like, okay, let's keep doing this.
Yeah.
This is awesome.
Well, that's cool. I think it's always good to get early wins too, like improve the concept, right? And it makes you feel good about what you can do. Obviously, a huge amount of savings. So he was happy, you were happy, you delivered value. Yeah. It'd be a struggle, of course, if like you were really the first few that came in the door, you couldn't help. Yeah. It'd be frustrating.
I'd be like,
But I think what it speaks to is it doesn't have to be a huge bill either. We were talking about this over coffee. I've heard the commonly cited stat that the average American, I think it's something like 70 to 80% of Americans can't afford a $500 unexpected or emergency expense.
Yeah.
So it doesn't have to be a $26,000 bill to put somebody in a position that financially strains them. And so you're probably not always seeing huge situations either.
No, some of them are smaller and people can't afford them. And so, that's when I get into, that's where it's like, well, is this a pro bono case? If I have somebody reach out and I can tell that they can't
desperate,
then I'm going to help. I'm not going to turn people away. Yeah,
because what are their alternatives? We were talking about, how you might pay for it otherwise, right? So you see commonly people are probably using credit cards, or what else might they use?
Well, if it's a hospital bill, they'll set you up on a payment plan, right? And those usually range from like 12 months to 36 months. So then you're paying for who knows how long. And the thing with that is, like you mentioned, a $500 bill, but that's a small bill. That's not even their deductible, right? If you go to the ER, you're looking at thousands of dollars. So let's just be hypothetical here. We've got a guy who's got a $4,000 bill from his ER visit, and he's set up on a 36-month payment plan to pay that off. What if he goes to the ER again next year?
Right.
And then it's just like, it's never going to end. It's just this endless stream of bills.
I look in the position, and that's a situation where like the $4,200 bill we had with my son, it wasn't so much a situation of an inability to pay. Yeah. It was just anger at the way that I was used, or he was used as a mechanism to charge that amount. So I think out of spite, if I had to pay that full amount, I probably would have set it up in the longest payment plan possible and just made them suffer collecting my $100 a month for 36 months just out of spite.
Yep.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
But I think what it speaks to more broadly, and I told you this when I had that post about my son, you've obviously seen it, is this is ubiquitous.
Yep.
This touches everybody in America. Everybody either is dealing with this themselves or knows somebody intimately that is dealing with an outrageous hospital bill, right?
Yep.
So it's not like this is an uncommon problem that's niche.
Nope.
You're addressing a space where there's going to be infinite demand for the foreseeable future. So tell me about the building of your business over the last couple of years. Coming out of COVID, did you see the activity and stuff pick up?
Yeah.
Okay, cool. So like, what type of stuff are you getting engaged in? I don't know if you have like your most famous story of your biggest savings or maybe your most frustrating case or challenging case. I'd love to hear about some of those types of things.
Yeah, I would say, so here's another fun one that I like to tell people about. A gal who reached out from Texas, actually. Her husband had a long COVID stay and was in the hospital for like 6 weeks, I believe. They had their only coverage was a hospital indemnity plan that said it would cover $100,000. So when he was discharged, their bill was $590 some thousand from this hospital stay. Insurance paid the $100,000 that they promised that they would. So she was left with $490 some thousand.
Good grief.
So when she called the hospital to say, I don't know what to do about this, what do I do? They kindly offered her a 36-month payment plan. I have to do the math here. 36 months, which
about
was
$15,000 a month or something?
$13,000 a month. That was their solution to her problem
great.
when she called. Yeah. So she reached out to me and I said, what was the name of the hospital? And she gave me the name of the hospital. I pulled up. I'm like, this is a nonprofit hospital.
Yep.
Did anyone offer you financial assistance? And she's like, no, absolutely not.
Of course they didn't.
No one offered her financial assistance. I sent her the link to the application. She filled it out. She responded like 2 weeks later, oh my gosh, Jenni, my balance, it's $12,000 now.
Yeah.
She didn't qualify for 100% financial assistance, but her bill was
95%.
Yes.
Yeah.
And no one even offered it to her. I never took $1 from her.
Yeah.
She was like, oh my gosh, I'm so grateful. I was like,
yeah, the financial assistance, and there's a tool that I saw recently, I forget the name of it, but it would track every state and what multiple of the poverty level you could be at from an income perspective and still qualify. And some of them are 500% or more of the poverty level, depending on the state.
Yeah.
But that's not publicly advertised, right? It's available information, but the hospitals certainly are going to proactively go, oh, by the way, go fill this out and you won't owe us anything.
It's always like a last resort.
They're not going to say that, right? And that's where an advocate, right, or even a good consultant will really step in. Have you had any cases, though, that were just maddening or that you couldn't help even though like there was an opportunity? Is there any really frustrating ones that have come across your desk? I hate to highlight the negative, right? But
I know, and I honestly
we can't solve every problem.
There are some times where people will reach out and say, something's got to be wrong, or this bill's got to be overpriced. And I get the bill, I get the EOB, and I have to say, I'm sorry, there's nothing wrong. And at that point, I've also done pricing research, and I'm like, and it's not really overpriced.
Yeah.
And so then I have to be like, I'm sorry.
It's
it
legit.
is what
You're
it is.
stuck. Yeah.
So those, I don't like those. I don't like to not be able to help anyone. So yeah, those people, I'm like, I'm sorry, it's an overpriced bill.
But see, but I look at the situations like that, and I think I want to be very careful I don't admonish hospitals for existing, or it's not like they don't have costs associated with delivering care. So like in that situation, when it is legitimate, it's priced appropriately, all the charges were reasonable. You just have to accept that that's also the reality of healthcare delivery, and that's why we purchase insurance often, is for those situations that financially we wouldn't be able to pay out of pocket, so you purchase insurance for an unknown risk in the future. Okay, cool. So the system is functioning as it was supposed to. That's actually rare, though, compared to the times when it's not functioning as it is supposed to. I was going to ask you this on the subject of price. I think you mentioned a tool to me over coffee that you use to sort of gauge the appropriateness of like a claims cost. What was that tool that you mentioned to me?
So there are two that I use when I'm looking at appropriateness and trying to negotiate a balance down. TriBilly, where you're familiar with TriBilly, we can go out and we can type in our zip code. You got to have your CPT code, CPT code, zip code, and then it's pulling from hospital price transparency files. So you can see, okay, what's the self-pay rate? What's the minimum negotiated rate? What am I being billed versus what everybody else gets to pay for this service?
Right.
And then the other one I love is Sage Price Transparency. That is a free tool that allows me to go on and find out at what percentage of Medicare a hospital needs to operate to break even.
Oh, okay.
Yeah. And
so it's a percentage above Medicare, though. Yes. So it's presuming Medicare is not break even for most hospitals, right?
Although, interestingly, I did find one not too long ago. University of Kentucky, when we met up this morning, I was on there.
Yeah.
Theirs is below Medicare. And I was like, this can't be right. And I reached out to the people who actually like put Sage together. And they're like, oh my gosh, we've never really seen this before. But it was because they're getting so much money from other sources that somehow
the Medicare they can lose money on, and
they were able to,
Or is that saying they are actually profitable at a margin below Medicare?
Yes.
So to me, that would speak to, and I don't know the business, but that speak to the running an efficient model if they can make money at a threshold lower than Medicare. Because the common outcry is that Medicare reimbursement rates are too low and unsustainable, and so therefore the private sector has to make up that margin, and that's why we pay so many multiples of Medicare on average.
Right.
Okay, so why do you want those two data points? So TriBilly, again, is more hospital price transparency and aggregating cash prices or the range of payments based on who the insurer was. And then you have this Medicare profitability benchmark with Sage. Do you typically use both benchmarks when you're looking at reviewing one bill? Okay.
Yeah, and then I can come up with a number that's reasonable.
Okay.
Right? Like, is it fair? Like, why do I have Cigna and I'm paying way more than a self-pay patient or even an Aetna patient? And then I can look at that percentage of Medicare break-even point and be like, look, I'll offer you even above that number so you can still make a profit.
How do the hospital billing departments react to you as an independent advocate? It's not related to the person. Like, how do you establish, one, that you're even able to represent that individual in the first place?
Yeah, that's all about HIPAA waivers.
Okay.
It's like the part of my job that I really, really hate is getting a HIPAA waiver on file. Okay. But yeah, I have to have authorization to speak on their behalf, obviously. And then, honestly, if I'm getting into fee negotiations, I'm not working with the people at the billing department anymore. I go straight for the top.
Okay. Oh, so like the CEO of the hospital or what?
CFO. Like, who's your CFO?
Okay.
I'll find if I can find their email, which they like to keep hidden, for sure, mailing address, if I can get the fax number for administration.
Okay.
Because for some reason in healthcare, we're still using fax machines, then I'll fax the negotiation letter over.
And what does a typical negotiation look like, right? So let's say we have a bill that's extreme for a number of different reasons, but mostly maybe it's just the reimbursement rates themselves are out of range. So then you find through those data points with TriBilly and Sage what a reasonable offer would be to make. And so that you go back and say, hey, you charge $10,000, but we'll offer $1,500 as appropriate. And that's like a starting point in negotiation? Is that how it typically starts?
Or sometimes they've already been paid by insurance more than what I think is fair. Like, I'll be
really?
$5,000's fair, and you already received that from Cigna, so leave this guy alone, right? That's just right off the balance.
So, and then, so like, do you track kind of like a success rate or like how often like those negotiations work? Because I see the smile, like, maybe not. I'm an analyst by trade. So like I logically think of like, well, what percentage of the time do you get it? And what percentage of savings do you get? And I realize that may not be exactly how you want to run it, but that's just how my brain
No,
works.
I do. I need to. Okay. So my quick answer is no, I don't track it as well as I should.
Yeah. But I'd be curious because I bet you can deliver pretty substantial savings. Yeah. And I think you probably know that, right? And I'm just curious because these hospitals, when they look at it, there's a reason they're charging such extreme amounts.
Yeah.
But that's because they know most of the time it's going to get discounted by the insurance company and ultimately down to some agreed upon rate for that service. But even that, I think most of the time that agreed upon rate has such variability across insurance companies that it never actually makes sense. And so you got to get to like establishing what's reasonable seems like it should be so obvious, but it's got to be a pretty frustrating endeavor as well.
It is frustrating, yeah.
Do they typically take your benchmarks with SAGE and Triability? Do they give those credence in negotiations?
They do. Okay. They do. I mean, I think because I do my research, like I know the background on the person's individual story, a lot of times, most of the time, I will tell them to apply for financial assistance first, and maybe they didn't qualify, so I can even put that in my negotiation letter. Like, don't come back at me with they need to apply for financial assistance because we've already done that. Yeah. And they still can't afford this bill. So there's a lot of time that goes into it, a lot of research, and they're usually, I'm sure they don't like me, but the response is favorable.
The response is favorable. So, and do you ever have to threaten like, oh, I'm going to go expose this story on Facebook or a podcast?
I haven't. Okay. I haven't. I always, it's funny, I was talking to another advocate the other day, and a patient was talking about her story, and she'd been declined financial assistance several times. She actually worked for the hospital that she'd been sent to collections by, which is a lovely story that I hear all the time. And my friend was kind of like, well, there's always like the media. You can go to the media, and there absolutely is. I like to give the hospital a chance to make good on their own first. Right. So I've never actually done that.
Well, I think that's good. Then that means the negotiation tactics you are using are working. Right. But there are certainly stories that end up in the media and for good reason, right? And maybe they are the most extreme circumstances, but those hospital systems don't want that bad press, especially when they're in the wrong, and it's pretty clear to show they're in the wrong. And so I would agree shouldn't be the first tactic, but it's an effective tactic as well.
In the back pocket,
if you need it. One of those really, really crazy stories, you'll pull it out. Yep. I was gonna mention something. I actually kind of used that in my own story with my son. Didn't want to put Cook Children's on blast, but I did state all the evidence and all the facts, and is this appropriate? I made sure to tag them on LinkedIn. Yep. I just wanted to at least use that as a leverage point, because I think I didn't attack them as an organization, but the bill itself. And I said, here's the evidence I've collected. You're charging me more than the 40 other examples of the same CPT code in the same location for the same service. Why are you discriminating against me and my son, right? Then here's the cash price that you'll accept. Here's the average reimbursement rate that you accept from insurance companies. Why am I higher than literally all of those data points? And that's, if you can tell me why I'm higher and show me the facts, then I might accept those. But there was no argument. And really, realistically, it didn't really rise to the level of them responding anyways. But the marketplace responded on my behalf and helped me out tremendously. Yep. And that's where it really created this level of awareness for me of what you do and the importance of what folks like you do, because I didn't realize how many people have to deal with this problem on a daily basis.
Everybody. And you're in the industry, so you know how it works. You know how to kind of talk the talk. You know what a CPT code is. I mean, most people don't. And so they need somebody to advocate on their behalf. I mean, the system is impossible to navigate on.
Well, let's talk about that then. Let's make the listener, if we can, a little bit better consumers of healthcare, because it's one thing for you to step in after something has already happened, but you were talking about even on the front end of ensuring the right network is being used when they go to submit for a certificate or a pre-authorization or something like that. So can we talk about the steps I could take the next time I find myself in the ER with my son or in urgent care? What should I be thinking about or doing just to ensure that crappy things don't happen?
First off, if you can avoid the ER at all costs.
Of course.
Right?
Yes.
Yeah, I have my husband and my 4 children are actually afraid to go to the ER now in case I'm like, unless you've been shot or you just chopped your finger off or you're like actually having a heart attack, the Nolans don't go to the ER. So avoid the ER at all costs. The further away you can get from the hospital,
the better.
The better. I like to tell people that. First off, if it can wait till Monday, yep. Obviously, some things are emergencies. So there's that.
Well, and can I say something about that? And I agree with you. And the reason we ended up in the ER is because it was 1 o'clock in the morning, and that was the only.
Sometimes you got to go. Yeah.
I wouldn't have said it was an emergency. We did it out of an abundance of caution because my little guy was having strained breathing and he was hysterical. He was 3 too, so you can't calm him down. I'm 100% agree with you. But the other part of me says, well, that sucks. That now we have to be terrified of going to the ER, not because we don't think they'll help us, because we think we're going to get screwed financially as a result.
So many people don't. It's horrible. It's horrible. It's like this catch-22 because I feel like ER prices are high because people are using it for everything. And then you've got people afraid to use it when they legitimately need it, because they're afraid of the bill on the other side.
Well, and even it's being used obviously by folks that are uninsured too, is like their doctor sometimes, because that's what they have access to and that's what they do for better or for worse. And obviously that creates a rise in costs as well.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
But let's say I did find myself in the ER. It was an emergency situation. I need to go. At least I'm lucid enough to fill out some paperwork, right? I'm not having a heart attack and sedated. What should I think about there when I walk in their sliding glass doors?
Oh, gosh. I guess if you're lucid enough to walk into an ER, you need to have made sure it's in your network.
Yeah.
I mean, that's something you can identify up front, right?
In terms of like paperwork or anything like that?
Paperwork. Okay, so there's a thing out there, and you're put me on the spot, so I can't think of it right now. But there are there's a recommendation out there that when you're signing your consent form on the way in, where you're kind of like signing your life away, I agree to be responsible for whatever my insurance says I am or whatever. To get that in paper, mark it out, and say, I'll agree to 200% of Medicare.
Oh, this must be a Marshall Allen thing. Yeah.
Marshall,
Yeah. I've heard him talk about that, unfortunately, obviously the late Marshall Allen, but I heard him talk about that, where it's like, you'll put in handwritten parameters of what you'll pay and then sign it, right? And just so at least you have that plausible deniability, or say, I will not agree. And if they accept that form, then that's their acceptance as well on the other side, to say that's the threshold that we'll charge.
First of all, you're at least going to get dirty looks when you ask for that, right? Because everything's done on a computer screen now. So just the fact that they have to give you the paper, and you're clearly like being a thorn in their side by marking things out and changing the lingo. And then where does that paper end up? So when the bill does come, it's not like the people in the billing office are going to be like, let me check their consent form to make sure
they weren't well informed on the front end and hand wrote some notes in there.
So I haven't had the opportunity of trying that yet, thank goodness, but I probably will if I end up in the ER. So that's one thing people could do, just so you're not agreeing to pay whatever comes at you.
Well, and then it's probably difficult to answer a question about like the navigation of services once they're recommended, right? Of like which test to accept or which scan to accept. I mean, that's really difficult because that kind of gets in the realm of like medical advice. So I won't put you on the spot.
And when you're in the ER, like
it's all coming at you.
It's just coming at you. And if it's a true emergency, you're going to do whatever it takes to, right? Like, oh, you need a CT scan. Okay, I better do that.
But it's just, and it's those incentives, right? Because once you walk in that door, it's an opportunity for revenue. And even out of an abundance of caution, if you could argue that this particular scan or test was appropriate, even though maybe it's a percentage of the time that it's actually likely you're having X event and therefore needed that, they'll do it because there's a few $1,000s of revenue generated for that particular test.
I like like to think that the ER docs aren't thinking that way. I like to think that they're just doing it because it's actually necessary. But I will say, like, the price of the scan in the ER is so much more expensive than the price of the scan down the street at the standalone facility. So again, the further away you can get from that.
Well, that's there's we talk about it regularly, but I just had tomorrow the episode with Rob Gelb of Valence, which is a company we really like and work with at Pareto. They acquired the KISS card, and so KISS card is one of those things where if you know you need an MRI and it's not an emergency situation, rather than just go where you were referred by your PCP, that company can step in and say, hey, Jenni, I noticed you need an MRI. Well, did you know if you went down the street here, it's only $600 instead of $3,600? Yep. And by the way, your employer will waive your out-of-pocket expense if you make that decision as well. An MRI is an MRI is an MRI, and then it's only as good as the person reading it afterwards, which is where the physician comes back in. That's a great example of getting yourself away from the ER and into a situation where you can intentionally navigate intelligently, and you save your employer money and you save yourself money at the same time, right? So like that's a little bit more of like you have time to think and it's less of an emergency situation. But then afterwards, what are things that you would suggest an individual look for if they think I've got an EOB that I think this looks like some of these charges don't look appropriate or look high? What are the most obvious things they should probably look for there?
So definitely request your itemized statement. I'm sure you did that with your son's bill, right?
I did,
so you need to see exactly what you were billed for line by line, because on that bill that comes, it's either going to be lumped into one line, you just owe $13,000 or whatever, right? Or it's going to say labs, $2,000, x-ray, whatever, like you need an itemized bill so you can see exactly what you were billed for. Okay. In the case of an ER visit, look at what level did they bill. So their code's either going to end in 1, 2, 3, 4, 5, that CPT code. Were you billed a level 5? Like, if you walked out of the ER, you probably shouldn't have been billed a level 5 office. Like, in my opinion, if you were billed a level 5, you're admitted to the hospital. Right. Like, you're not walking out of there. Yeah. So look at the code that you were billed. Okay. A lot of times when you get into arguing coding, then you're going to need to request medical records because it's all about what was documented. So that gets a little intensive, but it can take a lot of work, but save you a lot of money. Is
Upcoding the most common funny business, or what other funny business do you commonly see? And upcoding, just for folks that don't know, that's a term at least I've heard used when, in that example, they designated a level 5, but then they walked out and were handed some minor medication, probably wasn't a level 5. So upcoding is a severity level for your particular situation, and the higher the severity level, the more they charge as a result of that. Yep. So there is incentive, again, and we're just talking about incentives, there is incentive to upcode because it's more revenue that they generate. And then you have to then now go prove the other side. It shouldn't have been a 4. It should have been a 3, right? And you have to be able to navigate that, and that's challenging. Yeah. So I think upcoding is now even easier than it used to be because of the electronic, right? Like if I'm your doctor and I can just check a box that I just asked you XYZ as far as medical history, it's prompting you. It's prompting you to check these boxes and do these things. So it's frustrating because then a lot of times I'll request records and they're like, well, it's done electronically, and this he checked all the boxes. So well, I think that's where insurers do this. I think hospital systems do this. There's plausible deniability when technology gets inserted into the equation, because you can just say, well, I was just following the prompts of the tech. Or when it comes to like auto adjudication, well, that's just what the algorithm adjudicated and said was appropriate, right? So you can point to technology, which is nameless and faceless, and therefore cast the blame on the technology instead of the human error. And so it gives them a chance to say, well, we didn't do that. It was the system that did that, right? Oh, okay. Well, then once you prove eventually it was wrong, okay, you're right. We should correct that. But how many people are going to take the steps and know to even go and push back against that rather than simply accept it and pay it? Right. Yeah. And I think that's what they're counting on to a degree. Okay. So, all right. So I don't want to bash everybody and everything, right? And I'm not saying people are bad. I think sometimes when you get good people in bad systems, the systems win, unfortunately. But what do you envision this business being, right? Or in the future of what you're doing here? I mean, you obviously have a lot of fun and a lot of passion for what you do, but what is your ultimate goal, or what you want to do with this advocacy business?
So I think for me personally, I just want to spread the word to like the entire population. I mean, we're all patients. Everybody in this country is a patient. So this applies to all of us. And I think that the general public who's not in the industry like we are, I think that they think that healthcare is just expensive and this is just the way it has to be.
Yeah.
And it doesn't.
Yeah.
And I think if more people knew that, they would rise up and fight the system.
Pitchforks.
Fight for change. Yeah.
Yeah. Well, and so, with that groundswell of anger, and I'm in agreement with you, right? I think it does come down to a level of awareness too. And I think one of the best force vectors or levers that we can pull is the employer. We were talking about the 165 million Americans, half of the country gets their insurance or health insurance through an employer. So if and a lot of my audience is in the group benefits world, can you engage? Can you help an employer out? Would you just work on individual case-by-case basis with their patients? Like, how could you engage and partner with an employer who might be interested in this as well?
Yeah, that's interesting. I don't know exactly. I would love to be able to help employers out. So I don't know what that looks like as far as compensation or what that relationship looks like. I think it's absolutely an asset. It's definitely a perk for employees.
Yeah.
There's this whole presenteeism thing where when they're having these problems, they're having to make these phone calls during work.
Yeah.
Right? You don't get to call Cigna at 8 p.m. when you're home. So if an employee is struggling with a bill like this, they're trying to figure it out on work time.
Absolutely.
Essentially. So it's beneficial to an employer to have someone.
Well, the presenteeism that comes from the financial strain that they're probably feeling as well, like going, oh my God, how am I going to pay for this?
Yes.
We can't afford this.
It
What does
stresses
that do to
people
your
out.
psyche when you go to work as well? But I think at the end of the day, and I don't know if you charge a percentage of savings or a flat rate, but an employer would benefit from this as well. So I'm just thinking at like a self-funded employer who's got this, one of their individual employees has this huge bill, it's going to hit the plan for a large percentage of the claim as well. They benefit from this too, right? So it just comes down to who's paying for your services at the end of the day.
Yeah.
But if I'm a consultant listening to this right now, I'm just thinking, well, if I ever have somebody call in and say, man, we've got this huge bill and Sally is suffering as a result of that, there's nothing to stop you and Sally from getting engaged to work together, right? I mean, just knowing that you're out there as a resource.
Right. And for like HR departments, I mean, they probably get a lot of these phone calls, right? And do they have a dedicated person to help their employees with these situations? A lot of them don't.
Highly doubt
Some
it.
of them maybe, but
Well, a lot of times HR folks might have, and we deal with really small self-funded employers, so it could be an HR staff of one or two, right? Like I guarantee they're not well trained on patient advocacy as all the other hats they have to wear in their job. And so it just you need a specialist in this type of world. I mean, do you see the industry like growing? I mean, there's clearly a need for what you do. Do you see a lot? And I think you're even telling me you have peers out there in your network that you guys will share cases in between. Do you see like a lot of patient advocates popping up now?
Yeah.
Okay.
Yeah, and I love it.
You love it.
I think that most people don't know that we exist, and it's almost like every person needs a patient advocate because the system's not set up to navigate on your own, whether it's on the clinical side of healthcare or the billing side, like what I do. It's nearly impossible to navigate. So,
well, and I think if we were smarter consumers on the front end, that would be great as well, for sure.
For sure.
And that's why I was going to ask you some of those questions, because I think it does come down to healthcare literacy is a big component, or I'd say healthcare illiteracy is a big component of this. But then that you can't avoid, just because you're literate how to navigate the system doesn't mean you're going to not find yourself in an emergency situation.
For sure.
And so the other side of the equation is just ensuring there's a fairness associated with how you were billed. So let me zoom you out here, Jenni, before we get you kind of into the podcast. I warned you over coffee. We're going to talk about healthcare at large and the future of healthcare. What is your sentiment, since you've been in this space a number of years now and helping people with these types of bills? What do you think like we're going to see in terms of big changes in healthcare in the next few years? You get to cast your vision now for the future of healthcare.
I just hope we do see change. I know we talked about like I'm kind of passionate about the employer side, right? Because my husband owns a small business. So I do think employers have a huge opportunity to shift things, to change the system. My husband is an electrical engineer, so he offers his employees benefits, but he doesn't know anything about it.
Yeah.
Nothing.
Yeah.
So just educating people, and then educating consumers, again, like I said, just the rest of the John Q public, like this is the way it is and this is not the way it has to be. So I'm super passionate about that. So I've got like the paid side of my advocacy work where I'm like in the nitty gritty helping people with their bills. But then I'm also passionate about like, I went down and spoke before the State House in Indiana about support of a healthcare bill. So what can we do to fix it on the front end so that people don't need me?
So yeah, and so what does that look like though? I mean, you said even kind of tongue in cheek, but I don't think you're off base. Is have people in high school learn about this.
Yeah.
Have a class in high school on healthcare literacy.
Because we are
How
all
awesome
patients.
would that be? Yeah. Why shouldn't you know? I mean, you should know about personal finance. You should understand accounting. You should understand history. Why shouldn't you understand the $4.5 trillion industry? At least what a deductible is and a copay and what insurance means. Like that should be common knowledge.
It should be.
But I think, and this is not even a nefarious conspiracy, but I think the industry does benefit from people not being aware of those things, right?
Sure.
The more in the dark the average person is, John Q. Public, as you said, is about healthcare navigation, the more expensive things will be and the more profit to be made.
And they just think it's the way it is and it's the way it has to be.
Yeah. It doesn't have to be this way, Jenni. We're going to fix this.
We're going to fix it.
We're going to fix it. Well, and I think for me, I've chosen the path of awareness and education. That's where I think the biggest leverage we can get for this is a generation from now, right? So planting the seed now for as many young people as possible so that they grow up being much more literate than I was coming into healthcare, right?
Well, I think in our defense too, and people not understanding, and I don't want to date myself, but like when I graduated from college, there weren't high deductible health plans, right? So we kind of didn't care. I literally paid a $10 copay when I went to the doctor's office. So we didn't have to care about all this stuff. And now we do.
I think I've seen a chart of the last decade. Family premiums were up 55%, but family deductibles were up 110% during that period of time. So what you're seeing is the erosion of the quality of benefits over the last decade or so. So it's more expensive, yes, but the benefits are even doubly worse for more expensive health insurance as well, which sucks.
Getting
from both
less
sides.
for more.
Less for more. So all right, so Jenni, I know we've talked for probably how long have we been going, Nathaniel? 56 minutes. Okay, yeah. Usually in my internal clock says it's getting close to an hour. But Jenni, we've covered a lot of ground today, and I'm so grateful for you to come down from Indiana to be on the show. But if you were to leave people with one or two ideas or closing thoughts, like what is something you want them to think about before they go about their day?
I want them to know that if they are already facing a medical bill, whether it's overpriced, whatever the situation is, they can always reach out to an advocate for help. Doesn't have to be me. They're just Google patient advocacy, patient billing advocacy. You can find somebody. You don't have to do it by yourself. And then just try to educate yourself so that you don't end up with those issues in the first place. Sometimes they're unavoidable, but But
if you do find somebody like Jenni, and does it matter location, right? Are you helping people across the country?
People across the country. I've got actually a client in Alaska. I've got people in New York.
Very cool.
Fun, yeah.
Well, so we'll obviously make sure we tag your organization and you in every post, and the folks that want to get in touch with you can absolutely do that. But I would encourage them strongly. I've used healthcare or patient advocacy before. It absolutely works. There is a mission, there's a movement that's happening, right, to empower people to be better consumers and navigate healthcare. And if you find yourself in that situation, I would strongly encourage to call somebody like Jenni. So awesome.
Thank you.
That's my little commercial for you.
Yay.
And we did a podcast. We're done. Thanks, guys, for listening. Appreciate it.
Thank you.